Swagatam ma'am, are you with us? Madam? Kalaimani ma'am, good evening ma'am.
Good evening sir. Good evening,
madam.
Shashana sir. Good evening, sir.
Good evening, madam.
Good evening, sir.
We are waiting for you.
I had kept it on, sir. I was waiting for them to.
Good evening, all. Good evening, madam.
Good
Sir.
evening, sir. Dr. Hitesh, sir.
Sorry, madam. Good
Yes,
evening,
sir.
sir.
Hitesh, sir.
Yes, sir. Good evening.
Sir, Dr. Rajiv.
Good evening, sir.
Good evening, sir. Dr. Rajiv, sir.
Swagatam ma'am will be joining in few minutes. Kiledar ma'am, are you with us? Aviral, can you try sharing your PowerPoint, Aviral?
Friday.
Dr. Aviral,
Yes, sir.
can you try sharing your PowerPoint?
Yes, sir.
Make it full screen, Aviral. Just run through the slides fully. Madhura ma'am, Kiledar Madhura ma'am, are you with us? Give me 1 minute. Let me check, Madhura ma'am. Aviral, can you switch on your video, Aviral?
Sir, it's on, sir.
Okay, okay.
हाँ,
सर को भी बता देती हूँ क्योंकि ऐसा है बच्चे नेक्स्ट वीक बोल रहे हैं तो नेक्स्ट वीक सैटरडे संडे मेरे पास टाइम
आपका प्लान नहीं ना आपका आप
प्लान करके कर लो कभी भी। हमारा छोड़ो, हमारा ये लोग पूछना पड़ेगा कब करें। अमित कर
Okay, I think another Madhura ma'am is joining now. So can I request all the non-faculty and non-presenters to mute themselves? Please cooperate. Okay, good evening, friends. We have all the faculty joining up. Swagata ma'am, good evening. And Kiledar ma'am will be joining us shortly. With the permission of the faculty, we start this session of the PG clinics. We have two
9:30 க்கு நான் வந்துடுறேன்.
contributed by
10 o'clock
Kanna sir.
காலையில patient
Kanna sir
வரட்டும்.
has contributed Dr. Abiran.
9:30 க்கு நான் உங்க
He'll be
ஆபீஸ்
presenting. He'll be presenting a case on solitary nodule thyroid, and Dr. Divya will be presenting a case on right leg fossa mass. So we have invited faculty, Professor Swagata ma'am from AIMS Bhopal, Kiledar ma'am from Sangli, Bharati Vidyapeeth, and Kalemani ma'am from the MS Ramaya. And we have our senior faculty, Kanna sir, Rajgopal sir, Hitesh sir, Rajiv Sahay sir, Karnakaran sir, and other senior faculty, Dr. Lakshman Prasad sir. We warmly welcome Chairman Tamil Nadu ASI, Dr. Selvaraj sir, also to join us. So with the permission of the faculty, we start the session. Faculty, kindly take over. Good luck, Dr. Abiral. Please switch on your video. Yes, sir.
So shall I start?
Please, Dr. Abiral. Kiledar ma'am, welcome ma'am. Thank you for joining.
Good evening, respected teachers and all the colleagues. I will be presenting a clinical case on a topic of thyroid nodule. I'm a junior resident from General Surgery, IMS-BHU. My moderator for this presentation is Professor Ajay Khanna sir. My head of department is Professor Puneet sir, and guide is Professor Rahul Khanna sir. Coming to the case, this is a case pertaining to a 35-year-old female who is married, Hindu, homemaker by profession and resident of Gorakhpur, UP, who presented to our surgery OPD with complaints of swelling in front and left lower side of the neck for last 7 years. History of present illness. The patient was apparently asymptomatic 7 years ago when she noticed a swelling in the left lower side of the neck, which was insidious in onset. Initially small in size, approximately 2 centimeters in size, in the left lower side of the neck, which gradually progressive in size to the present size of approximately 8 cross 6 centimeters, extending up to the front part of the neck. There is no history of any associated pain or rapid progression in the size. There is no history suggestive of intolerance to heat or cold, altered bowel habits like diarrhea or constipation, unintentional weight gain or the weight loss despite a good appetite, restlessness, palpitation or chest pain, inability to sleep, lethargy, irritability, menstrual irregularities,
नको MRI cancel केलाय,
tremors, weakness of the limb, difficulty in standing up or climbing stairs, vision or double vision. Stated history of pain, trauma, difficulty in swelling or difficulty in breathing and alteration in voice, any other swelling in neck elsewhere, bone pain or swelling, cough, breathlessness, blood thin sputum or pain abdomen, headache and seizures. Coming to the past history, there was no similar complaint in the past. There is no history of any hyperthyroidism or hyperthyroidism diagnosed, or any other comorbidity like hypertension, type 2 DM, history of tuberculosis, asthma, COPD or cardiovascular accident, epilepsy or any other chronic illness. There is no history of any prior irradiation to the head, neck or chest, mainly in the childhood. And there is a history of open appendectomy done 15 years ago. The personal history, diet was mixed, appetite is normal, there is no disturbance in the sleep cycle, bladder and bowel habits are regular and normal, and there is no history of any substance abuse. Menstrual history, she had her menarche at 13 years of age. Menstrual cycles are regular of 5 days and the cycle duration is of 28 days plus minus 2 days, and associated with her normal flow. And her last menstrual period was on 27th of February. Coming to obstetric history, she has 2 life status, all spontaneous vaginal delivery, and the last childbirth was 8 years ago. Family history, there is no history of any similar illness in the family members or in the neighborhood, and there is no history of malignancy or any malignancy-related death in the family members. Treatment history is non-conclusive. Summary, this is a case of 35 years old female with painless swelling in the front and side of the neck for last 7 years, which was gradually progressive in size to present size of approximately 8 × 6 centimeter, with no features of hyperthyroidism, any pressure symptom, or no history suggestive of metastasis, and no significant family history associated.
Shall we stop at this, sir? Shall we ask them some questions?
Yes, madam. Yes, madam.
The other faculty. Yeah, Dr. Aviral, you've completed your history?
Yes, history part is completed, ma'am.
Completed. At the end of the history, what do you think is your diagnosis?
Most likely it is a benign swelling of the thyroid, ma'am, because there's a history of long-standing history of 7 years, and with a gradual increase in size, and no history of any rapid progression or any associated pain or involvement or any.
Aviral, you don't have to give reasons. She's just asked you what's your diagnosis. You'll just
it's
say this is my problem.
Swelling of thyroid, sir.
So what is the diagnosis?
It's a benign thyroid swelling, sir.
Why do you think you think it's neoplastic? Neoplastic means benign or malignant. Can it be anything other than neoplasm?
Sir, it could be cases of papillary carcinoma which have a they sometimes can.
No,
have
why are you thinking of
progression over,
neoplastic? Aviral, why are you thinking of a neoplastic swelling? Neoplastic could be benign or malignant.
It's not neoplastic because, sir, it is.
No. Hang on. Aviral, you said benign.
Yes,
benign means it's a neoplastic which is benign. Neoplastic means benign or malignant, isn't it?
Yes, sir.
Right. So, are there other swellings other than neoplasm?
Sir, kindly repeat, sir.
Are there any other diagnosis other than neoplasm in your case?
It could be a case of goiter, sir.
Goiter means any swelling of the thyroid. Can you be more specific? Can it be a multinodular goiter?
Multinodular goiter, it could be. It's goiter, sir.
It's a simple goiter which could be multinodular. It's a simple multinodular goiter because the patient is euthyroid clinically by history, isn't it?
Yes, sir.
So that should be your first diagnosis rather than benign. If you mention benign, you're thinking of something in terms of neoplasm. There are others which are much more common, isn't it?
Yes, sir.
What is the other differential diagnosis of swelling in the anterior part of the neck?
Ma'am, it could be lipoma or lipoma of subdermal lipoma, and cases of
Aviral,
yes.
please.
Start from the submental area.
Now, sorry, ma'am. Other swellings does not mean you start naming sebaceous cysts, lipomas, hemangioma. Be specific. Give us the differential other swellings of the thyroid.
Thyroglossal cyst could occur in the midline. Thyroglossal fistula can occur in midline. Dermoid can even occur, sir.
No, hang on, Aviral. Give me other differentials related to thyroid.
No, may not be other differential related to thyroid, but other swellings which can come in the anterior part of the neck.
Okay, she's asking a general question.
Yeah.
I would have expected other.
Other thing also, I think what madam is asking. Why do you say it is thyroid only? Can it be anything else? That also you.
Yeah, because from history we cannot say it's only thyroid.
Yes,
There
exactly.
can be another swelling.
This is why I stopped you, Aviral.
Ma'am, based on the history, ma'am, there was a swelling which arose from the left side of the neck, and it was extending to in the midline, which was a typical reason of the thyroid swellings, ma'am. And
No. We are asking this question depending on the history which you have provided. Now,
yes, ma'am.
still we are not done the examination, we are not done the inspection. So
Yes, ma'am.
from history, what may you think, what are the different swellings which come in the anterior part of the neck?
On the basis of history of for last 7 years, ma'am, painless swelling, most likely it is a thyroid swelling. Otherwise, in midline of the neck, ma'am, dermoid, thyroglossus cyst, and even lipoma and subdermal lipoma, like these conditions can occur in the midline, ma'am.
Can't it be a lymph node?
Kindly repeat, ma'am.
Can't it be a lymph node?
Lymph node or any other cystic swelling?
Ma'am, lymph node and cystic swelling can occur in the hygroma and all. They don't generally occur in the midline, but Ludwig's and ma'am, for a duration of 7 years, ma'am, and painless swelling, so we can successfully rule out Ludwig's angina and ranula. These we can rule out.
They may not be there.
Yes, ma'am.
Okay.
Where do they occur? Ludwig's and what did you say? Ludwig's angina and ranula. Where do they occur? Do they occur in the neck, the region which you points out?
Sorry, ma'am, your voice is not audible.
No. Is it? Do you think ranula and all those things will occur in the neck in that region?
Ma'am,
for you to even consider?
I'm based on the region of the swelling and presentation of a painless swelling for last 7 years. I means we cannot keep them in differential.
Anyway, just to summarize, see, you should not straight away jump into conclusion that it is thyroid swelling only. You should keep your mind open. You should consider all the swellings that occur in the anterior triangle. Divide the neck into triangles and go understand all the anatomical structures and the differential diagnosis. Not exactly jump to thyroid alone. It could be a lymph node, it could be cervical. Why not tuberculosis lymph nodes in the beginning of your history? So you didn't ask any history of swelling elsewhere in the neck. Did you present that? You didn't give, right? Am I audible?
Sorry, ma'am, I have difficulty listening to your voice, ma'am. Is volume is listening.
You can't hear me?
Pardon, ma'am.
No, what I was telling is it can be, it could be a lymph node also. Even tuberculosis lymphadenitis can occur for a period of 7 years, slow growing.
Ma'am, it can occur, but it is a lymph node in such region, ma'am, and not associated with any fever, history of any fever or any other complaint is unlikely, ma'am.
They don't present with fever, no, all the time,
but there is no history of any similar.
You must give all this history. You have to rule out all these things. Don't just jump to one diagnosis. And you straight away jump to diagnosis of thyroid and straight away jump to tumors and straight away jump to papillary. That is not acceptable. So you have to go. You have to keep your options open. Fine.
Yes, ma'am.
Okay.
You can go ahead.
Thank you, ma'am. Coming to general fiscal examination. Examination was done after taking informed consent.
Sorry, one moment. Family history, you said no other malignancies. What do you mean by that?
Ma'am, if we are suspecting, ma'am, thyroid malignancy, okay, and we have to rule out associated conditions, ma'am, like Cowden syndrome and any other BRAF mutation or even MEN syndromes. So was there any associated complaint of death from malignancy of GI origin or some, so that I was trying to rule out.
Did you ask all these things to the patients?
Ma'am, basically I asked for any GI malignancy and any, so there was not any suggestive history, ma'am.
You must be specific in that again, okay? All the syndromes and the associated malignancy in the family. As a PG, you need to mention that. There was no history suggestive of so and so.
Yes.
Okay? Yeah.
Another thing, you said that LMP of this patient is 27th of February. So yes, is she having symptoms or amenorrhea is there or any?
No, ma'am. No, ma'am. Normal flow is there and cycles are regular of 28 to 30 days.
Okay, but okay. It may be this time they may be delayed menses. Okay.
Yes, ma'am. But I took the history, ma'am, 1 week back.
Okay, okay. No problem. I thought you have taken yesterday or today.
Coming to general physical examination, examination was done after taking well-informed consent in a well-lit room in presence of a female chaperone, and the patient was sitting comfortably. Patient was conscious, cooperative, well-oriented to time, place, and person. She was moderate build and had adequate nutrition. BMI was 22.26 kg per meter square, against for a height of 160 centimeter and weight of 57 kilograms. And Karnofsky performance score was 90, and ECOG was 0. Coming to vitals, she was afebrile on touch. Pulse was 82 beats per minute in right radial artery, which was of regular rhythm. Normal character, adequate volume, no radial or radiofemoral delay was present. PPA was 118 by 80 millimeters of mercury, measured in right upper arm in the supine position. Respiratory rate was 16 per minute, cycles per minute, which was thoraco-abdominal and regular. And JVP was not elevated in this case. There was no pallor icterus cyanosis, clubbing, period edema, or generalized lymphadenopathy. There was no abnormal hair loss or coursing or thinning of the hair. No abnormal facies was present. Upon examination of oral cavity, she had a good hygiene of oral cavity with normal dental framework. No dryness or no tongue tremors were visualized. No dryness of skin was present, and no hand tremors were present. Coming to local examination, after taking informed consent, exposure was done from neck up to the chest in presence of a female chaperone, and the patient was examined in the sitting position with arms by the side. Coming to inspection, there was a globular swelling of size 8 × 6 centimeter in the anterior and left aspect of the neck, the thyroid region, which was extending superiorly up to the upper border of thyroid cartilage, inferiorly up to the suprasternal notch, laterally up to the posterior border of the left sternocleidomastoid, and medially extending 2 centimeter beyond the midline. The surface of the swelling was smooth and the margins were well defined on inspection. The skin above the swelling was normal. The swelling moved with deglutition, but not with the protrusion of tongue. Inferior margin was well defined, and it was also visible on deglutition. No visible pulsation or engorged veins were seen, and there was no other swelling in the neck, and Pemberton sign was negative for this case. Coming to palpation, there was no local rise of temperature or tenderness. A 8 × 6 centimeter globular swelling in the anterior and left aspect of the neck, the thyroid region, which was extending superiorly up to the upper border of thyroid cartilage, inferiorly 1 centimeter above the suprasternal notch, and laterally up to the posterior border of left sternocleidomastoid, and medially up to 2 centimeter beyond the midline. The surface was smooth and consistency was soft to firm. The margins were well defined, and even the lower margin was palpable. There was no fixity to the skin or underlying structure. There was no palpable pulsation or thrill. The swelling was mobile side to side and vertically. Trachea was not palpable owing to the large size of the swelling, but the Cocker's test was done and it was negative. Left carotid pulsation was palpable and was lateral to its normal position, and there were no palpable cervical lymph nodes. Coming to percussion, a resonant note was heard over the manubrium sterni, and in auscultation there was no audible brew heard, and trachea was in the midline. Ocular examination, there were no except Helmholtz thyrotoxic eye signs for conjunctival congestion. There was no palsy and ocular movements were executable in all directions. And coming to deep neuromuscular examination, deep pendant reflexes were normal. There was no hand or tongue tremors. No protrusion or limb muscle weakness. No proximal limb muscle weakness were there, and the power was of the proximal limb muscle was 5/5. There was no lower limb swelling or skin changes, and no digital deformity was present. Systemic examination was essentially normal for CNS, CVS, respiratory system, per abdominal examination, and skeletal system, that is midline and skull examination. Finally summarizing my case, This is a case of a 35-year-old female with a painless swelling in the front and side of the neck for the last 7 years, which was gradually progressive in size to present size of 8 × 6 centimeter and associated with no features of any hyper or hypothyroidism, pressure symptom, or no history suggestive of metastasis, and without a significant family history. Upon examination, the general survey was essentially normal. There was a globular, soft to firm, non-tender swelling of size 8 × 6 centimeter in anterior and left aspect of the neck in the thyroid region, extending superiorly up to the upper border of thyroid cartilage and inferiorly 1 centimeter above the suprasternal notch. Laterally up to the posterior border of left sternocleidomastoid and medially up to 2 centimeter from the midline. Moving with deglutition but not protrusion of the tongue, with no cervical lymphadenopathy or infiltration of the surrounding structure.
Okay.
My provisional diagnosis for this case is a non-toxic solitary thyroid nodule involving the left lobe, probably benign.
Okay. So, in your history, in the examination, you have told that Pemberton sign is negative.
Yes, ma'am.
And you told that the lower margin is palpable.
Yes, ma'am.
So, was it necessary to tell? Because when we say that the lower margin is palpable, that rules out that it is not a retrosternal goiter. So,
Yes,
I think you should not say about the Pemberton sign here. So, it will be negative.
Yes, ma'am. Pardon, ma'am.
Okay.
In physical examination, what should be the position of yourself when you are examining a thyroid swelling? The patient position, sitting by the side, okay, what is the position of the neck and where will you stand?
Ma'am, initially on palpation, ma'am, we have to stand behind the patient, ma'am, with the neck flex and our thumb fixed on the midline, and we have to palpate with both using the 4 fingers of the both hand. And later on in the palpation part, we can come in the front of the patient and we can examine the specific lobe, ma'am.
What are the different methods of palpation?
Ma'am, basic palpation is done from the posterior side, and lobe, to palpate a lobe in a better way, we can come in front of neck and execute a Leahy's method, in which the lobe we want to palpate, we have to push it push the other lobe using and then we can palpate the specific lobe. Even if the swelling is small or fine nodules are present, we can execute it using Price method, in which we ask the patient to do deglutition and we palpate the surface of the thyroid for any gross enlargement in the thyroid or fine nodules. Small nodules.
Any Pizzola's method? What is
Pizzolo
Pizzolo?
method is, ma'am, is done for inspection, ma'am, in which if the swelling is small and we have to better delineate the swelling, then we ask the patient to clasp his both hand and put pressure against the hands over the head, ma'am. So the swelling is more better visible.
Visible.
Do you know what is the WHO grading of the goiter?
No, ma'am, I don't remember.
Okay, it is when we see on inspection, as soon as the patient comes, if the goiter is not visible, so it should be grade 0. Then we extend the neck if it is visible on extension. If it is visible, then it is grade 2. And if it is visible on inspection, it is grade 2, 0, 1, 2. Okay.
Thank you. Thank you.
You know what? How we test for the plane of the swelling? There is a question from Dr. Sajdev. How we test for plane of the swelling?
Still an inspection, I think.
Plane swelling, ma'am. Like we
What
have
is
to
the plane of the swelling? The question by Sachin to it is, what is the plane of the swelling?
Ma'am, this swelling we have to define that swelling in this region is arising from skin or arising from any deeper structure. We by contracting the sternocleidomastoid, if it is a thyroid swelling, If by contracting thyroid stenoglymatoid, if it is a thyroid swelling, it subsides because it is deep to the pretracheal fascia, deep fascia. Also upon degradation, also ma'am, even upon degradation, if it moves, it means it is attached to the deep fascia. So
Yes, it is deeper to the pretracheal fascia.
so
That
with the movement of larynx, ma'am, it also it moves.
yes.
Why does it move, doctor?
You need to be little more
Yeah.
clarity
Yeah,
in
yes.
expressing your answer. The very simple question: what is the plane of the swelling? It is
Pardon,
neither
sir,
you should
I
not use the word under this fascia or above the fascia, because always it is enclosed within the fascia.
yes, sir.
It is within the fascia. That is why it is there is a fascia behind and there is super. So always better to say there is only investigation you can do is only by doing the deglutition. It's as it moves on deglutition, you can say. Otherwise, you cannot make independently a strap muscle examination or putting the sternocleidomastoid both the muscle together. All these examinations are not needed. Just because if you can know that it is moving on deglutition, you can very well say it is within the pretracheal fascia. And
Yes.
similarly, when you presented the Lagis and Kreil's method, do you think the Kreil's method you are going to palpate the swelling nodule?
No, no, no. Just I asked what are the different methods, not for the
No,
swelling.
I mean, madam, sorry, because he said that in a Kreil's method, he is going to see for the minor nodule, he is going to palpate.
No, sir.
Okay.
Even enlargement of the diffuse enlargement of the thyroid is also palpable, or some nodules are also palpable
Kreil's
on trials.
method, you are not going to do any palpation separately. In the Lagis, you are seeing for a nodule.
Yes,
Then you are keeping your thumb static on the nodule and asking the patient to declutinate, move his
degradated. Yes, sir.
nodule should move under your finger and your finger should be static. You are not going to do the palpation on your that finger. The
Yes, sir.
swelling is automatically going to move. The lag is the opposite. You are fixing the swelling and you are going to palpate the nodule. So there is a basic difference. I mean, you must be able to very clarify and say the examination part is more important.
Yes, sir. Thank you, sir.
Why did you do Fiscal's method in this patient, Dr. Avira?
Ma'am, your voice is not audible.
It is a huge swelling, right?
Yes, ma'am. Yes, ma'am.
Then why did you do Fiscal's method on him?
Ma'am,
on
I
her?
means
He
I didn't do, ma'am.
Yeah.
No, I thought he showed a picture where her hand is behind her head. I did see a picture there. So it's not indicated,
Yes, ma'am.
right? Yeah.
Just for
No, don't do that. Don't do that. See, you
Okay,
are
ma'am.
PG, whatever you're doing, the examiners will be watching you.
Yes, ma'am.
Okay, so Fiscal's is done only, as you said, short neck, and the swelling is not visible. Basically
Yes.
for short neck. Okay, so you ask her to extend and then you see, right? So don't unnecessarily tell everything.
Yes, ma'am. Thank you,
Be
ma'am.
careful, yes.
Viral, I have one or two questions to you. That is, did you mention the consistency and a little more details anywhere? I might have missed. You said skin is smooth surface. Can you show the palpation quickly? Just one slide. Yeah, just, yeah. 1 minute. Yeah. Surface is smooth. Consistency is soft. So at least it's a deeply seated under the pretracheal fascia, such a large cystic swelling. So
Yes.
if you are asked what you can mention for eliciting fluctuation, that's what I wanted to ask. You understand?
Yes, sir.
Tell me. This is a very
So-
large one, na?
Yes, sir.
Suppose somebody says it may be a lipoma. Lipoma is also soft.
Yes, sir.
You understand, no?
Yes, sir.
There's a possibility. You said just now lipoma is one of the, not here, but so you may have to say that here. I did my either a Paget's test, especially tensely cystic swellings. You get an yielding feeling here. Don't expect it to fluctuate. You know, your finger may dip in.
Yes, sir.
Actually, one look of this swelling will tell it looks like a nice, globular cystic swelling, right?
Yes, sir.
That has to come here, number one. Number two, Madam said WHO classification, if you extend the neck, it becomes more prominent. Correct. Why it become more prominent? When you extend the neck. Correct, no? See,
Yes,
all
sir.
thyroid swellings you observe. You ask the
Yes.
patient to extend the neck, it become more prominent because of some amount of cervical lordosis. You understand, no?
Yes, sir.
When you extend the neck, there's some lordosis. It gently pushes the thyroid gland. That's
Yes.
one of the reasons why it becomes more prominent. I'm not very sure. You mentioned carefully the carotid, trachea, etc. Where did you auscultate for or hear the trachea in your patient? Trachea.
The trachea I auscultated.
Where? Just
Sir, trachea was not palpable. For auscultation part, basically at the lower margin of the swelling, lower margin of the swelling, near the lower margin of the swelling, I auscultated.
That is why I asked you here. Here, see, don't by heart the things and go in the examination. That is what a PG should know. You can't get the lower border here. No, you only say very close there. But you can see the upper border actually.
Yes.
Yes or no? So at least you may have to keep your step there above.
Yes.
You understand?
Yes.
And here for the sounds. I don't have the cursor. Actually, you yourself can show.
Yes, sir. Yes, sir.
Yeah. Yes. And one more comment is, actually, you can show with your cursor the round border on the right side. So on the right. So you don't have to mention as, it is a medial border. If I'm not wrong, you said medial border, correct?
The anterior border of sternocleidomastoid.
So you may have to just say it is very close to the anterior border of the sternomastoid. And if you see on the other side, you see how the sternomastoid has been pushed. You understand? Yeah.
Yes, sir.
And carotid artery, you mentioned?
So it was the lateralized from its regular position, sir.
No, nothing like a regular position and all that.
Means
make a habit of
compared to the, yes.
So that you will not miss in the exam. All regular, all these words are not expected. A large, wide, large.
Tell the regular position.
So, ma'am, compared to the
sir is asking you, tell the regular position.
Compared to the other side of the neck, ma'am, it was lateralized.
No. You said regular position. Please, tell the regular position. Sir asked you that.
The regular position, theoretically, ma'am, it is localized at upper border of sternocleidomastoid at the level of thyroid cartilage against the tuberculosis.
Upper border of the thyroid cartilage, it bifurcates. So
yes,
below that, below along the C6 tubercle. Okay.
Yes, sir. Next tubercle, C6 tubercle. We against it, we palpated.
So that's why. So don't use this regular word. So you understand. Be specific while reading. Okay.
Yes, sir.
First, is it swelling involving both the lobe or a single lobe? The swelling arising from both the lobes or a single lobe it is arising?
Sir, pardon, sir, your voice is not audible, sir.
No, but the swelling is from both the lobes or from the single lobe?
Sir, single lobe, sir, left lobe, sir. Right lobe was.
So your measurement is 8x6 and you are saying it is a globe.
Pardon, sir, your voice is not much audible.
There is one question. What is Berry's sign?
Berry's signs, ma'am, it is due to involvement of carotid fascia, ma'am. The carotid pulsation is absent. It's mostly found in malignant swelling, ma'am.
Yes.
Yes, define. Question is what is Berry's sign? You should first define. Then you tell what is the cause for it. Always.
Again, Aviral.
Yes,
so nothing like a regular. See, you said carotid. What sheath is? What is it? Some word you used. Infiltrated. Inward. Some. See,
yes,
what you should understand is it is engulfing. See, the better word. You know why you want to use that word? Tell me why.
So, actually, the tumor, it actually surrounds the carotid, and we are not able to palpate just because of that, sir.
So how do you know that lumen is still intact?
Yes, sir. Lumen is yes, sir. We cannot rule out on palpation, sir.
No. There is a method in which you can still say carotid is work. That's why I asked you all this. Be clear in your thoughts. You examine the superficial temporal artery. You understand?
Yes.
The superficial temporal artery is normal, means carotid is still working condition. Otherwise, you would have got stroke or whatever it is. You understand? So it's more of a engulfment, it's almost goes around. Actually, it is a carotid sheath. you use the word carotid fascia, correct?
Carotid sheath.
So please correct. All these things are very small things, but important things. Yeah.
Yes, thank you, sir.
Well, what are the various ways of looking for the trachea in a thyroid patient?
Sir, on inspection, sir, we have a trail sign. In trail sign, sir, if the trachea is striated, that ipsilateral side sternocleidomastoid mastoid becomes prominent, sir. And otherwise, we can palpate it using a 3-finger test. We can palpate the from the upper part of the neck till the lower border. We can palpate the course of the trachea, and also we can auscultate for the tracheal sounds. It's normal breathing sounds passing through the trachea.
When you were showing the tremors demonstration on the hand,
yes, sir.
Where did you put the paper? Can you show that?
Yes, sir.
Where are you putting that?
So, over the fingers, sir, because distal tremors are present.
It has to be put over the metacarpals and the digital bones or the phalanx.
Yes, sir.
Okay, so it has to come in the central part of that. Not only the distal part, it has to come in the central part of the hand. You know, over the metacarpals and the phalanx.
Yes, sir. Thank you, sir.
And you said something about the digital deformity on your examination. What is the distal deformity you were looking for?
Sir, in cases of thyrotoxicosis, sir, thyroacropathy can occur, sir, and it's a very rare finding, but upon thyroacropathy, distal deformity occurs, sir. Bone resorptions and myxedema features, suboptimal bone resorption and deposition can occur, sir.
And what is pretibial myxedema?
Sir, in pretibial myxedema, sir, in the region of shin or part of the leg, sir, there is deposition. We can visualize discoloration present, sir. Due to deposition of glycosaminoglycans in such cases of primary thyrotoxicosis.
So if you say it is a case of a solitary thyroid nodule, what is the differential diagnosis of a solitary thyroid nodule?
Sir, solitary thyroid nodule could be carcinoma or even a lymphoma.
What is the commonest cause? What is the commonest cause of solitary thyroid nodule?
Colloid goiter.
It's a part of the multinodular goiter, okay?
Yes, sir.
Or a colloid goiter. Almost about 60% of them are the benign. That's why Dr. Shai was asking you that. What are the other differential diagnosis of the solitary thyroid nodule? So the commonest is the colloid nodule, or it's a part of the multinodular goiter. What are the other causes of the solitary thyroid nodule?
Sir, it could be a dominant nodule, or it could be thyroid adenoma or carcinoma. Even lymphoma cases can also lead to it. Cystic thyroglossus cyst could also lead to a case of, it could be a differential diagnosis of solitary thyroid nodules.
No, you are missing again one thing very important, which is there in the thyroid. Where you can manage it without any very active treatment.
Goiter.
Goiter you told about that. Colloid goiter you told. Thyroid cyst.
Thyroglossus cyst.
Yes. Not the thyroglossus cyst.
Thyroid cyst.
Thyroid cyst.
Yes, sir.
thyroid cyst. No?
Yes, sir.
So that is also quite common as a part of the solitary thyroid nodule.
Should have given that as one of the differential
Then as a thyroiditis, no? Thyroiditis can present as a thyroid abscess can present as a solitary thyroid nodule. Thyroiditis can present as a solitary thyroid nodule. So all those are the differential diagnosis of the
Solitary thyroid nodule.
solitary thyroid nodule. Okay. Okay.
Okay,
Can go on. Yeah.
how do you
Yeah,
manage
Dr.
this
Sai.
case now? That's so. How do you manage diagnosis of a solitary thyroid nodule? Now, how do you go about?
So, pardon, sir, your voice is not audible, sir.
I said you've got a working diagnosis of a solitary thyroid nodule. So
Yes, sir.
now how do you go about?
So
What's the next step?
first we have to do confirmatory tests, sir. We order thyroid function test, or basically TSH we order. According to the levels, based on the levels of TSH, it could be low or normal, or it could be increased, sir. We have to.
Clinically, the patient is euthyroid. Aviral, clinically the patient is euthyroid.
Then we have to progress with.
Right. So next step would be what?
USD, sir, and based on USD, sir, and we can proceed with FNAC too, sir.
What will you look for in
Aviral,
ultrasound?
as in case of breast lump, we always say whenever it is asked that we will do a triple examination, isn't?
Yes, sir.
So similarly, now everyone should tell in a thyroid examination that we will do a quadruple examination. Okay. You know that quadruple examination?
Sir, history and clinical examination, and radiological USD and FNAC, and a biochemical test, thyroid function test.
So this is a quadruple now. Okay.
Yes.
So in any case of a thyroid swelling which is there, you have to say that we are going to do a quadruple examination for this patient. Okay.
Yes.
Yeah.
Okay, you're doing ultrasound. What do you want to look for in ultrasound, doctor?
Ma'am, on USD, we will look for the the whole gland, and we have to identify any nodule. We have to look for the texture of the nodule, size of the nodule.
You have the patient. You have the patient. In this patient, what are you going to look for in the ultrasound report? What is the first thing you want to see?
We have to rule out the high risk features, ma'am, in such case.
No, Aviral, you're being biased by having a diagnosis, I think. See, it's a swelling. It's a solitary nodule, you said.
Yes, ma'am.
You want to do an ultrasound. What do you want to see in that ultrasound? You simply ask for ultrasound?
If it is a thyroid swelling or not.
That it's moving with deglutition, so you know it is thyroid.
Yes, ma'am.
Right? You want to confirm? Okay, fine, confirm. So what next?
Then we have to
what will an ultrasound pick up? Sir gave one of the differential diagnoses.
No.
Dr. Ajay gave you one of the differential diagnoses. So you must know what you want to look for in an ultrasound.
It is a single enlargement of the gland or multiple nodular goiter.
First, it is whether it's solid or cystic. Sir gave a diagnosis of solid thyroid cyst, isn't it?
Yes, ma'am.
And an ultrasound is one thing which picks up whether it is solid or cystic. That is the
cystic.
diagnosis of investigation of choice, right?
Yes, ma'am.
That's important. So first thing you will say whether it is solid or, okay, you want to say it's a thyroid or not. Second thing is whether it is solid or cystic. Then what next?
Then, ma'am, if it is then we have to look for the size of the nodule shape and number of the nodule. We have to look for vascularity of the gland, and for microcalcification or rim calcification, and any extra thyroid extension is present or not.
You will get to know all this in ultrasound?
Ma'am, we can visualize, ma'am, on high frequency ultrasound.
Okay, so do you think patient has extrathyroidal extension based on the clinical examination?
No, ma'am.
No. Okay, so what will you look for in ultrasound? One is, again, I'm repeating. You said whether it's thyroid or not, solid or cystic. Next important thing is whether it is a dominant nodule, whether there is the rest of the gland has nodules or not is important. Next is whether there are lymph nodes or not. Then you said vascularity. Why do you want to look for vascularity?
Ma'am, in cases of hyperthyroidism, ma'am, vascularity increases, and we can confirm it clinically also with blue or not. But otherwise, in cases of malignancy, also means
Malignancy here, not hyperthyroidism. Please understand here. Your patient is clinically euthyroid, and whether she is hyperthyroid or not, you will get to know from your thyroid profile. Not ultrasound is not diagnostic of thyroiditis. Please remember. There are certain things we are looking for in ultrasound.
Yes, ma'am.
Okay. In this particular patient, only these. If it was a multinodular goiter, then things are different. I don't want to talk and confuse you. You understand when you ask for ultrasound, you have to know what you should read from the ultrasound.
Yes, ma'am.
Okay. Okay. Now.
Thank you.
Next. Other.
In ultrasound, how does the radiologist they report finally? What do they say?
Sir, in current scenarios, they report on basis of thyroids, and thyroids, sir, it is determined by 5 parameters: the composition of the nodules, and the shape of the nodules, taller than wide or wide than taller, a composition of solid, cystic or mixed, then hypoechogenic or hypoechogenic or isoechogenic, or then we have to rule out the irregular margins, and presence of calcification, microcalcification or rim calcification is present or not. And they also mention the involvement of any cervical adenopathy is present or not. Based on cervical, apart from
so these are all the things you see on the ultrasound, to make the final reporting of the thyroid.
Yeah, on the basis of the 5 points, we determine a score, and on the basis of the score, we assign a thyroid's level to the region. So, and a radiologist reports in the form of thyroids. So.
What is a thyroid incidentaloma?
Sir, thyroid incidentaloma is sir, thyroid nodules which are which rise during the routine workup without any indication for ordering the tests. In current scenario,
why somebody will give why somebody will do some test without any indication? Why somebody will do the ultrasound of the neck or any examination of the neck without any indication?
Sir, to look for any other pathology, sir, and there is an incidental finding of thyroid nodules.
Like any other pathology, which is the commonest indication of carrying out the ultrasound of the neck, where you are not suspecting the thyroid pathology.
Haven't completed what you want, what you have to say, incidental loma. When is it picked and what size it is?
You want to see the carotids. That is the commonest indication.
Yes.
Okay, if somebody has got a TIA or the stroke is there, you want to work up whether his carotids are okay or not. That is the commonest indication of carrying out the ultrasound of the neck, where in that you find that the patient has got a thyroid incidentaloma.
Yes.
Okay.
You have the ultrasound report? You have the report, doctor?
Yes, ma'am.
Can you read it out?
USD was done, and it was suggestive of left lower enlargement, approximately 7.6 cross 5.5 centimeter. It was hyperechoic with few cystic lesion, and the mass was causing adjacent mass effect and displacing the carotid vessels and trachea, but there was no infiltration noted, and there was no retrosternal extension. and rest of the finding were normal. And based on the reporting, based on the finding, ma'am, Thyroid's 2 or 3 lesion was reported, and benign thyroid mass was suspected.
Okay. So what next you will want to do?
Ma'am, we can.
Srivastava, sir has asked you the thyroid incident. Is it only with ultrasound?
Sir, even on a clinical examination, sir, if we can, and even then we can diagnose as incidental.
Suppose you somebody find out by the CT.
Sir?
If some investigation is being done on a CT scan, MRI.
Even on the, other radiological investigations, CECT of neck for any other cause we have, or CECT neck and thorax for any thoracic lesion, and we diagnose
and also FDG, when you have a PET scan. So that also can produce an incidental loma. PET scan, when you are doing that, you can have incidental findings on that.
Yes.
What is the size of the thyroid incidentuloma usually? What is the size of the thyroid incidentuloma usually?
Less than 1 centimeter.
Less than 1 centimeter.
You're guessing?
And if it is the adrenal incidentloma, how much is that? Adrenal incidentloma?
Centimeter.
How much?
Less than 2 centimeters.
No.
Sir,
4 centimeters. Right?
4 centimeters. Yes, less than 4 centimeters.
And if it is liver incidentloma is there then?
Sir, I don't know, sir. Liver incident.
Liver incidentloma usually is a cystic, like there's a congenital cyst is there, so it can be up to 8 centimeters.
Yes.
Okay.
What next, doctor?
After USG, ma'am, we got FNAC done, and FNAC report is given here. It was suggestive of benign follicular lesion, which was most likely colloid goiter, and Bethesda category was 2.
What do you mean by this Bethesda 2?
Means it is a benign lesion, ma'am.
You have to tell me the classification, Bethesda.
Ma'am?
What is the Bethesda classification?
Ma'am, kindly repeat, ma'am.
Bethesda classification, please elaborate on that.
Bethesda classification. Bethesda classification, ma'am, category 2 is benign, ma'am. 1 is non-diagnostic. Category 2 is benign. 3 is atypical of undetermined significance or follicular lesion of undetermined significance. Category 4 is follicular neoplasm or suspected follicular neoplasm. Category 5 is suspicious malignancy, and category 6 is confirmed malignancy.
If it is,
Ma'am?
Is it for follicular carcinoma, the Bethesda?
Ma'am, it is a reporting, Bethesda reporting, ma'am.
For any FNS, because
yes,
you
for any
follicular
yes.
cells every now and then.
Yes, for any lesion.
Dr. Jailal has some questions, sir.
If it is category 2 benign, what is the percentage of malignancy possibility?
So approx 3 to 6% possibilities here. So we do a regular follow-up.
So when will you follow up?
Regular follow-up is done, so 1 yearly follow-up can be.
Aviral, this is a very large swelling, quite a big swelling.
Yes.
There is some displacement of
the background noise, a lot of background noise, which is disturbing.
So I just want to know that it is benign. It is Bethesda grade 2. All that is correct. But do you have any indication for surgery in this patient? My question. There's some noise there.
Yes. So it is a large swelling, and large swelling which is displacing the carotid, and Otherwise, and cosmetic issue with the patient could lead to surgery. The main indication is cosmetic, sir, in this case.
Okay, the question which is commonly asked to PGs at breast cyst as well as thyroid is, when you aspirate, suppose you get a blood stained fluid, what will you do? No, one report is there here, colloid, that is correct. But suppose a cyst has got a blood, you aspirated the blood.
Yes, sir.
So basically, you want to rule out a malignancy. That is what is important. Okay.
Yes.
Chances are very, very negligible. Breast is one area. Repeated aspiration, 2 times you aspirate, it still fills up, cosmetically affecting. I personally feel that in that situation, safely you can go ahead and do a left hemithyroidectomy. That is what is probably looking at the large size size of this, because in no way you will reduce this unless you aspirate repeatedly. That is what I think so in this patient, right? Some noise is coming from somewhere.
The noise is really very disturbing. If Dr. Kanagavel, can you please look into it?
I think Dr. Sundaram sir wanted to ask some questions, sir. I am seeing who is that?
Okay, sir, he said the indication for surgery here is mainly cosmetic. Dr. Avirat?
Yes, ma'am.
Is it just cosmetic here? Mainly, you said it's mainly cosmetic.
Ma'am, in this case, ma'am.
Okay, if you want to do surgery, what surgery you want to do?
We should proceed with, ma'am, do rule out any future risk, ma'am. We can proceed with total thyroidectomy, and we can.
You just said it is cosmetic surgery.
Yes, ma'am.
And now you are saying total thyroidectomy. There are 2 different things in what you are saying, isn't it?
Yes, ma'am.
Is it cosmesis for this patient? I want to ask this question again to you. What is the patient?
Actually, the patient didn't have any other complaint except the swelling, ma'am.
Doctor, what is the FNAC report?
FNAC is a benign colloid goiter, ma'am.
Benign follicular lesion.
Suggestive of colloid goiter.
Okay.
Yes, ma'am.
So follicular lesion, what does it mean? It's not neoplasm?
Ma'am, could be, ma'am, because there is if follicular lesion is given and it denotes category 3 or 4, then there are up to 60% chances of malignancy.
Yeah. So here the only indication for her is cosmetic, you mean to say.
Ma'am,
what about the size? Is the size an indication?
Ma'am, given a large swelling, ma'am, we should proceed with.
Large means like what size, doctor?
Ma'am, a swelling of more than 4 centimeters should warrant surgical intervention.
More than 4 centimeters, is it just surgery or it's something more than that? More than 4 centimeters is an indication for surgery, or what type of surgery?
Ma'am, total thyroidectomy.
Total thyroidectomy. It is an indication for total thyroidectomy. What are the other indications for total thyroidectomy? See, this is a solitary nodule. In a solitary nodule, you will preferably do a hemithyroidectomy. And solitary nodule at surgery is always advised. Why? Surgery is advised in solitary nodule. Why?
Yes, ma'am.
Why?
Ma'am, means there are chances of malignancy, ma'am. According to the rule of 12, ma'am. Yes, ma'am.
So what is the percentage of malignancy in solitary nodules?
Ma'am, depending on the rule of 12, ma'am, if it is an isolated or dominant swelling, and taking into the consideration solid and cystic swelling, ma'am, there is a different chances of malignancy in male and female, ma'am. If we are taking into account dominant swelling, then the solid swelling have 12% chances, and which double up in 24% in men and reduce to 6% in females. If it is a cystic swelling, then it has 6% chances, which doubles up to 12% in men and 3% in female. If it is an isolated swelling, ma'am, it already has a double chance of malignancy. So for solid lesions, it turns out 24%, which increases to 48% in males and 12% in females. With a cystic swelling, then there is a 12% chance, which increases to approximately 24% for males and 6% for females. According to the rule of.
So which category she belongs to, this patient?
Ma'am, this is a isolated swelling, ma'am.
So more chances of malignancy,
yes,
right? So you have to do surgery. Now, based on the size, you want to decide what type of surgery.
Ma'am, total thyroidectomy we have to proceed with.
What are the other indications for total thyroidectomy?
Ma'am, pressure symptoms are there and features of malignancy are present, as well as hyper and hypothyroidism features are present.
Hyper and hypothyroidism. It's not like that. See, if it is more than 4 centimeters, one of the indications.
If it is a hard, firm to hard nodule is there, with extrathyroidal extension is there, ma'am.
In that condition, FNAC will give you your report, right?
Yes, ma'am.
So it is, even if FNAC says malignancy, there is no second thoughts.
Yes, ma'am.
So if it is FNAC says as malignancy, then you'll go on other categories like AGs and MEs classification. Based on that, you may proceed with surgery. But here I'm asking about a solitary nodule. You said size more than 4 is for total thyroidectomy. What are the other indications I'm asking you? Presence of atypia alone in FNAC also is an indication. Family history of thyroid cancer will be an indication.
And a past history of radiation.
Yes. So these are the indications for total thyroidectomy in a solitary nodule. Okay.
Yes. Thank you, ma'am.
Viren, why you want to do a total thyroidectomy in this patient?
Sir, means it is easily manageable. Easy to undergo a total thyroidectomy and manage it in post-op with thyroxine supplementation. If we proceed with subtotal thyroidectomy, sir, and
no, I'm not saying subtotal.
No. I think
nothing like subtotal now.
Yeah, we should stop you for subtotal. I think
hemithyroidectomy, sir. If we proceed with hemithyroidectomy, then in case of any future lesion, the subsequent operation is difficult, and there are much more chances of complication in subsequent operations.
No, you are, I think, probably not clear about that. If you are doing the hemithyroidectomy on one side, while in this patient it is a Bethesda category 2 is there,
yes, sir,
a benign follicular lesion, other lobe is absolutely normal.
Yes, sir.
So why asking for the total thyroidectomy in this patient? The patient will be on lifelong thyroxine treatment there.
Yes, sir.
And if you do only the hemithyroidectomy on one side, in case if there's a recurrence in the other lobe is there, then in that case you can do it. That's a virgin area. You can go ahead and do the surgery in that. So I think this is a patient where one should not go for the total thyroidectomy, because the cosmetic reason, if you want to go, you can go for the left hemithyroidectomy in this patient. And that too, though it is 8 centimeter lesion is there, now the people have started removing even the bigger lesion by the minimal invasive technique. So rather than going for the open thyroidectomy in this patient, one can go by the various type of the minimal invasive techniques for the removal of thyroid, especially for the cosmetic reason. So tell, what are the various minimal invasive type of the thyroidectomy?
Sir, various routes are possible, sir. Transoral and retroauricular, and from transaxillary approach as well as.
So which one was the first one?
Sir, transaxillary.
What is BABA?
Sir, I don't know, sir.
B.
So I don't know, sir, from BABA.
It is bilateral axillary. Okay. So
yes,
you go through the, either through the, you can go through the breast or you can go through the axilla. So they were the initial one. And then the patient started, you started going through the vestibule of the mouth.
Yes.
Okay, and then you can go to the, and the recent one is the robotic surgery, which is there. Even the robotic surgery is being done for the thyroid now.
Yes.
Okay.
On to the next case.
Yeah. Aviral, what you should also understand whenever you are presenting, what is the why this cyst has occurred. Why in multinodular goiter we do a total thyroidectomy? The concepts are different, no? So there is a stimulation from TSH, no? So you have the fluctuating T3, T4. So
Yes,
it equally, it stimulates both right lobe, left lobe, isthmus. Maybe some are some big nodule, small nodule. So that is the logic. This your case is only a unilocular, actually putting it that way. In
Yes,
fact,
sir.
the right lobe isthmus, according to the ultrasound report, is absolutely normal, correct?
Yes, sir.
Till you take out the entire isthmus, even if you at surgery, you get only one lobe. Why do you do that? Take out the whole isthmus. This is one common question which is asked. Even if in your case, let us, it's only the left lobe is enlarged, isthmus is normal, still you take out the entire isthmus because of isthmus is one of the isthmolobar junction. There's a common site of a nodule formation. You understand? So
Yes.
better to take out that entire the entire isthmus, and maybe to go to the extent of people used to tell earlier, a small cuff of the opposite lobe. In your case, it is not required. Okay.
Yes,
And don't think that doing a total thyroidectomy, even in good hands or whatever, may have a complication. See, hypothyroidism is easy to manage. After all, billions are taking Altroxin, 50 or 70. What is more difficult is what? Hypocalcemia. Understand?
Yes, sir.
Taking the calcium, 2 tablets, 3 tablets, it seriously causes constipation and other complications. So it is very, very difficult to manage hypocalcemia rather than hypothyroidism. Of course, I think you know all other complications, including recurrent nerve paralysis, etc. Yeah, that's all from my side.
Srivastav, you have put us, what is the TSH value? It's 139 nanograms per deciliter.
So
Your
actually, yes, sir, it was a within normal limit, sir. Well, that unit I have put, sir, it is wrong. The thyroid profile.
And you are doing pre T3 or pre total T3?
The total T3 we got for this question.
Why? Oh, you are particularly this patient I have done total T3. Is there any reason for that?
So otherwise we order for free T3 and free T4, and this patient it was.
No, that is what I'm asking. For
yes,
this patient, you ordered for total T3. Is there any special reason for that?
No, sir, no special reason, sir. It was advised, and
so it is under your whims and fancy. You are ordering either total or free, or
yes.
Or what is that value mean? I'm not clear on the values which are quoted is not doesn't fit into any values.
Yes, sir. I admit, sir, it was wrong, sir. Otherwise, it was essentially within normal limits, sir. Or the thyroid profile was normal. The value have been put wrong.
So
yes.
suppose this patient has a hypothyroid feature. What do you think? Suppose this patient has benign Vedastar-2 and also hypothyroid.
Yes, sir.
Solitary nodule with the TSH is low, or you have a TSH values normal, or hypothyroidism features. Will you do any other test?
Sir,
okay. Will you think of the possibility of any thyroiditis, it's Hashimoto's, anything like that?
thyroiditis involving a single lobe is Hashimoto can occur, sir, but in which there is a transient hyperthyroidism and subsequent hypothyroidism could occur, sir. So
what is transient hypothyroidism?
Sir, in
what do you mean by transient hypothyroidism?
Sir, due to infiltration of lymphocytes, sir, and there is a initially there is a thyroid. that due to lymphocytic infiltration and destruction.
No, Srivastava, please tell how do you get hyperthyroidism in Hashimoto's thyroiditis or any thyroiditis?
Sir,
It's not only for Hashimoto's. Any thyroiditis will produce initially transient hyperthyroidism.
So due to prior to destruction of glands, sir, there is a release of thyroxine hormones, sir, and
So how will you, when a patient comes to you, how will you differentiate whether this is from the transient hyperthyroidism or from the hyperthyroidism?
sir, based on TSH value, sir.
TSH values will be equivocal sometimes. You will not be able to, in a secondary thyrotoxicity, you will not be able to very categorically say, but just because of the TSH value.
So then
If it is from the Graves disease or
based on the complaint of the patient and clinical examination as well as sir, on basis of ultrasound.
You cannot make it out by a clinical or ultrasound.
So based on the complaint of the patient.
Antibody test you do? Any antibody test?
Sir, I don't know, sir. Antibody.
Sir,
antibody test we do. Sir, pardon, sir, I heard antibiotic. So antibody test we can order for Hashimoto's thyroiditis. Anti-TPO antibody and thyroglobulin, anti-thyroglobulin antibody we can do. These are the most specific ones, sir. And we anti-thyroglobulin antibodies and anti-TPO antibodies we can order, sir.
What is the confirmatory for thyroiditis or Graves disease?
So FNAC. Yes.
No.
Antibodies.
Graves you are not supposed to do the Graves FNAC, no?
Yes, sir.
When you are suspecting. So it is only iodine uptake scan. What will be the uptake scan in a thyroiditis? What will be the uptake scan in a Graves disease?
Sir, if a low TSH with features of hyperthyroidism and we are suspecting Graves disease, and we can order for iodine uptake, radioactive iodine uptake scan, sir. In thyroiditis, sir, there is a diffuse low uptake, sir. And in
that is only
disease,
after
sir,
when you are doing.
Yes, sir. In Graves disease, there is a diffuse increase uptake, and in thyroiditis, there is diffuse decrease uptake, sir.
There will not be the follicles are ruptured, so there will not be uptake of that. So that will be able to differentiate whether this is due to the transient hyperthyroidism or not.
Yes.
So when you have a solitary nodule also, when you have a doubt, then you can go for a isotope scan, especially when the TSH value is low you are getting.
Yes, sir. Thank you, sir.
So suppose your results comes as after you have done a hemithyroidectomy, it comes as a papillary carcinoma.
So then, depending if the age of the patient is less than 40 years, or the size of the nodule is less than 1 centimeter, and there is no extra thyroidal extension, or there is it was a unifocal lesion, sir, then we can continue with the present status, sir. Otherwise, we have to convert. We have to plan a total hysterectomy, sir.
So for your patient.
So.
For your patient, suppose you are doing a hemithyroidectomy, the result comes as a papillary carcinoma. What you will do?
Sir, in this patient, we will convert it to total hysterectomy.
Because it is more than 4 cm, high risk group it comes.
Yes.
I think we have to conclude.
Yes, we'll move on to the next case.
Yeah.
That's true. It's quite a bit of time. The thyroid is endless. There are questions.
Yeah.
Too many.
Yeah. Well done, Dr. Aviral.
Thank you. Thank you, ma'am.
Yeah.
Thank you, teachers.
We'll go to the next case.
Shall I start, sir?
Please
Yeah,
start
go ahead. Go ahead.
this class.
Good evening to all the respected teachers. Myself, Dr. Divya, from Institute of Medical Sciences, Banaras Hindu University. I'm going to present a case on right iliac fossa mass under the moderationship of Professor Ajay Khanna sir. My HOD is Professor Puneet sir, and my guide is Professor Seema Khanna ma'am. A 56-year gentleman from Siwan, Bihar, farmer by occupation, presented with complaints of pain in the right side of lower abdomen for 5 months and passage of black tarry stools on and off for 2 months. As stated by patient, he was apparently asymptomatic 5 months back when he complains of pain in the abdomen for 5 months, which was localized to right side of the lower abdomen. It was insidious in onset, gradually progressive, dull aching in nature, continuous, non-radiating. There was no aggravating factors and pain relieved on taking oral analgesics. Patient also complains of history of passage of black tarry stools, which was foul smelling on and off for 2 months. It was of multiple episodes, not associated with constipation, diarrhea, mucus discharge, or fresh blood in the stool. History is associated with generalized weakness for 1 month, and patient also gives history of loss of appetite and loss of weight in the form of loosening of clothes. There is no history of fever, night sweats, vomiting, abdominal distension or obstipation. No history of cough, breathlessness, hemoptysis, jaundice, back pain, chest pain, headache or convulsions. Next is the past history. Patient is not giving any history of known comorbidities or surgical intervention in the past. No history of tubercular contact or anti-tubercular drugs intake. No history of previous episodes of pain in the abdomen. Coming to family history, there is no history of any colonic, other gastrointestinal, pancreatic, breast cancer, cancer-related death in the family. Personal history, patient is vegetarian by diet, non-smoker, non-alcoholic, normal bladder habits, his sleep pattern was normal. So concluding the history, 56-year gentleman presenting with dull aching continuous pain in the right side of lower abdomen for 5 months, associated with passage of black tarry stools on and off for 2 months with associated loss of weight, loss of appetite and generalized weakness.
Divya, from looking into history, you said that black tarry stool. Yeah, now, have you asked the history about taking the hematinics?
Yes, ma'am. Patient is not taking any medication except the analgesics, ma'am, which he was taking for pain.
Actually, you should have stated here there is no history of hematinics. Why? Why I'm asking that?
Because, ma'am, iron tablets causes the black discoloration of the stool.
Yeah,
So
that is one thing.
Cause.
Yeah, that could be the cause. So you should have asked that.
Yes.
Another thing you asked, you have written here, there is no history of pancreatic, this thing, malignancy and all that. Do you think the patients will tell you all this history in our India?
No, ma'am. According to symptoms or whether any patient has been, any family members have been diagnosed with any cancer or has led to death, I have asked, ma'am.
I know why you are asked. I know why you are asked, but I don't think you have to write down like this. No history of any malignancy. I think that should have been.
भाई देखो कभी वो 2.5 लाख का ला रहा था, कभी 2 लाख का ला रहा था, कभी
Vimal Kumar, please.
मतलब उसने
Vimal Kumar, please close your mute yourself.
Okay. There is any history of aspirin intake?
Where do you think the pathology is? What you are suspecting in this case?
Sir, according to the history, it is looking like intraluminal GI pathology. It could be, according to the site of the pain, it could be, sir, from the cecum or the appendix or the ascending colon or the ileocecal region, sir.
So normally you get a black tarry stool from upper GI bleed.
Yes, sir.
So how do you explain that?
Sir, if there is a slow transit time and if the bleeding occur in the lower GI and it will take more than 16 hours of time to reach to the rectum, then it can produce black tarry stool.
What is the difference in that two?
Sorry, sir?
What is the difference in that color, black color? Why it is happening?
Sir, in case of lower GI bleed, it is because of the bacterial deconjugation of the hemoglobin, which leads to the black discoloration of the stool.
It is upper GI.
In upper GI, it's an acid hematite.
In upper GI, it is because of the acid will act on the hemoglobin and it will turn it into the acid hematite.
It is not only the hemoglobin conjugation, it is also the reduction, oxidative reduction of the hemoglobin that is happening with that. That is why you can get still the lower GI bleed also. You can get the Thyroid too.
Consuming
you are thinking and intraluminal lesion pathology.
Yes,
malignant pathology.
Yes, sir.
Malignancy.
Yeah, more in the favor of, sir, according to the age of the patient, more favor towards the malignancy.
What prompted you to think in terms of malignancy in this case?
Sir, first is the age of the patient. Patient is old, age 56 years. Then duration of history is 5 months.
Never say that, doctor. Please never say 55 is the old age.
Okay, sir.
So
Middle
never
age.
ever use that term, old age. Okay.
Yes, sir.
Safely tell only age.
Yes, sir. Age.
Don't come in. Okay.
Yes, sir. Age of the patient. Then duration of the history is, sir, for 5 months, and pain is localized to the right lower abdomen, and it is associated with black tarry stool and with significant weight loss, sir, and loss of appetite with generalized weakness.
So right colon pain, that means it is cecal pain.
Sorry, sir.
You mean to say because it is localized to the right iliac fossa,
No,
so it
no,
is
sir.
cecum. The pain is arising from cecum.
No, sir.
You should have missed only that. See, sir caught you on that. Pain is not
Pain
a feature
abdomen.
of malignancy, right?
Yes,
So
yes,
you
ma'am.
are, and if at all you talk about pain, the pain should have been probably due to obstruction or obstructive features.
Yes, ma'am. Or in the advanced case of
So you
malignancy.
should not have told that. Sir caught you exactly.
Divya, it is better to say right colon rather than cecum, appendix, and all.
Yes.
Can hepatic flexure growth can present with the right iliac fossa pain? With this picture of tarry stool, it's not uncommon. Can it present with the right iliac fossa pain?
So hepatic flexure is usually located in the right hypochondrium. So in case of any malrotation or something,
No. That means you don't know. That means you don't know that simple answer. So the answer is very simple. Hepatic flexure is a narrow area that is blocked. Now I give you a clue.
Oh.
What is the clue?
Closed loop, yes, sir.
Closed
sir,
loop.
ileocecal wall will be, sir, competent, so backflow won't be there.
So you also should know. So better to say right colon rather than be specific to cecum, etc.
Yes.
Your history of flow of history was good. Okay.
Thank you.
Go with the examination.
Why not tuberculosis?
Sir, usually tuberculosis presents in the young age group, sir, and patient will have the long history with intermittent pain abdomen. Here, sir, just 5 months history of pain and previous episodes of pain abdomen is not there, sir. And usually in tuberculosis, sir, a patient will be having vowel sounds, which he or she will be able to.
No, we are only in the history, we are still in the history only.
So long duration of history with intermittent complaints, sir, but patient is not having any previous complaint of pain abdomen.
No, Divya, don't just go fast on whatever you said. Whatever you said, nothing is was right. Okay, see, we can see Dr. Jailam sir saying no there. Okay,
yes.
It is not that. It is not that. Sir is asking some different thing. Why not tuberculosis with all these features?
It could be, ma'am, it could be a tuberculosis. So after examination,
by history, how will you rule out? By history, how will you rule out tuberculosis?
Ma'am, in history, tuberculosis usually patient will having the long history and with intermittent complaints.
More specific.
Diffuse pain will be there, ma'am. Colicky type of pain.
No.
Constitutional symptoms.
Sir, ma'am, patient will be giving history of fever, night sweats,
evening rise,
and constitutional symptoms will be there.
You have to rule out the constitutional symptoms and history of positive contacts also.
Yes.
History also you have to rule out.
It is not prolonged history. They present with protein symptoms. In the sense, the symptom can be very non-specific. They need not have abdomen symptoms at all. And symptoms may appear only when they go in for complications, that is obstruction.
Yes.
Fine, they can present with obstruction, they can present with peritonitis. That means most of them are asymptomatic. Constitutional symptoms are very important. So whatever is said does not say, yes, this is tuberculosis. Fine? It could be there, but we are not in favor of tuberculosis. Okay?
What are the other differential diagnoses of swelling in the right ilia fossa?
Ma'am, it could be from the retroperitoneal origin. It could be retroperitoneal tumors or the undescended testis. It could be, or the ectopic kidney, ma'am. It could be.
Okay. What else?
Ma'am, in case
it's a
of
male or female, ma'am?
in case
It is
of
a male
female,
or female?
Male patient.
Male, sir, male patients.
Male
In case of female, it could be some tubo-ovarian mass. It could be.
Let's stick on to this patient. Don't jump. Let's not.
Yes.
Yeah. Okay, go ahead with the physical examination.
Yes. Coming to general physical examination, patient was examined in a well-lit room after obtaining informed consent in presence of male chaperone. Patient was conscious, well-oriented, and cooperative at the time of examination. He was average build but poorly nourished. His hydration status was adequate. His BMI was 19.43. ECOG score was 1. Patient was afebrile.
Why do you put the patient on ECG score 1?
Sir, patient is able to do his all routine activity, just the restricted strenuous activity is restricted. So, ECOG 1, sir.
So, is it ECG 1 or ECG 0 only?
Sir, ECG ECOG 0 will be patient will be only the symptomatic, but strenuous activity he can do. But in ECOG 1, strenuous activity patient won't be able to perform, sir. So,
no. Strenuous for you may not be as strenuous for me. There is no very bad called strenuous work you do. Whether he is able to do normal work, routine work, his lifestyle work is there. So this patient comes, but your BMI is very low. Do you think 5 months duration history will produce such a low BMI and lesion? So your history elicitation, I don't think that the right iliac fossa mass which you are saying within a 5 months patient will go for such a poor nourishment. And what is the cause for that?
Sir, because of the maybe occult disease which patient has.
That can only produce anemia. That can produce anemia. You are saying that is the nourishment is poor.
Loss of
and anemia
appetite.
is totally different.
Sir, even patient is having the loss of appetite. So.
All these are not a common feature of you have a right left
because of the cachex.
And another thing
in malignancy, because of the cachexin release, sir, it can lead to the.
So it looks like you have a predetermined idea to put all the features into the malignancy and try to
my history patient is having.
Okay, and
it's a male patient. Okay. Go ahead, madam. Go ahead.
On examination, patient was afebrile. His pulse was 92 beats per minute. His blood pressure was 106 by 60 millimeter of mercury in right arm, spine position. His respiratory rate was 14 breaths per minute. Pallor was present. No icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. Coming to examination of the abdomen, this is the clinical picture of the patient. Coming to inspection, abdomen was distended, vague fullness noted in the right lower abdomen. Umbilicus was centrally placed, inverted, all quadrants moving proportionately with respiration. Overlying skin appears to be normal. No visible pulsation, peristalsis, venous engorgement, or scar mark. Hernial sites were intact. No flexion deformity at the hip joint.
At the financial scar is seen or not? Some transverse scar is seen at the pre-pubic area.
That is just the skin is like this, ma'am. There is no history of any previous surgery or scar was seen.
Okay.
Coming to palpation, a lump of size 8 into 6 centimeter is palpable in the right iliac fossa, which was extending to the right lumbar region. It was of irregular surface, well-defined margin, non-tender. Temperature was not raised over the swelling. Swelling was hard in consistency, non-mobile. On leg raising test, swelling decreased in the size. Swelling was not bimanually palpable or bilateral. No other lump or organomegaly was palpable. On percussion, upper border liver dullness was present on the 5th intercostal space. in the mid-clavicular line. Liver span was 12 centimeter. Percussion over the lump was dull. There was no evidence of free fluid in the abdomen. On auscultation, normal bowel sounds heard. External genitalia were normal on examination. Bilateral testes were normal. On DRE and proctoscopy, anal tone was normal. No growth or pelvic deposits felt. Fecal staining of finger was present and no blood stain. There was no spinal tenderness or deformity, no flexion deformity of hip joint, renal angles not full, it was non-tender, left supraclavicular lymph node was not palpable. On systemic examination, central...
Wait, show the abdomen examination. Why did you look for no flexion deformity at the hip joint?
Ma'am, in case of psoas involvement or psoas abscess, there will be flexion deformity at the hip joint. So
they will have what to say, black tarry stools.
Hello, ma'am.
Will they have black tarry stools?
No, ma'am.
Then why do you suspect any psoas abscess? You yourself told that it's an intraluminal pathology, yes, and now you're looking for other features of tuberculosis and what to say, psoas abscess.
Ma'am, in case of advanced malignancy, if it will infiltrate the psoas muscle, then that side of the hip joint can go into the flexion deformity because of the involvement of the psoas muscle.
So is it a routine examination for all malignancy of right colon that you examine the hip joint?
No, ma'am.
It's not a
You are
routine.
stretching your imagination.
Usually in case of
you are inviting here. You are inviting question. Now, sir is ready to ask you questions or totally on tuberculosis of the spine now. So you can, isn't it? You are inviting trouble by giving all these extra points, you know.
Yes.
Should be talking about it. Go to the next slide also. You have said local rise, no local rise of temperature. What do you mean by that?
Ma'am, where the swelling is situated, over that area, temperature is not raised.
What do you want to rule out by looking at the temperature there?
In case of any inflammatory swelling, ma'am.
No, can you tell one intra-abdominal malignant swelling will cause the temperature?
In malignant swelling, sir, it won't be there, sir. In benign swelling.
Okay, let me
tell me one benign swelling. Intra-abdominal benign swelling causing a temperature.
You can say for
parietal swelling, sir. For
you can say
swelling.
Parietal wall swelling. So then why do you want to unnecessarily? You are already well explaining. Then suddenly you are coming in the local temperature. Local temperature only for the parietal wall swelling.
Divya, you can say for completion of the examination, I have told.
Yes, ma'am.
So see, you should understand that if it is an intra-abdominal axis, how do they present? How do they present? Any intra-abdominal abscess, how can they present with?
Ma'am, a patient will be having fever.
Right? Stop at that. Fever. So there's no question of local rise of temperature. For an intra-abdominal abscess to produce local rise of temperature, that should have ruptured into the rectus muscle, then come to subcutaneous tissue, come to the skin, then only you can feel for local rise of temperature. And it's too wild an imagination.
Yes, yeah? Yes.
Don't talk about it. Local rise of temperature is only for parietal wall swelling. So, for example, there is swelling on the wall, then you talk about it.
Yes,
fine. So
do you have any mobility of the swelling? You said non-mobile.
So it was a restricted mobility. So mild swelling was present just side to side, but more of the restricted swelling.
You are mentioned as a non-mobile.
Non-mobile towards the swelling. So it was more towards the fixed swelling, sir. I was not able to elicit mobility.
No, there is mobility you check by respiration,
it was fixed.
movement on respiration and intrinsic mobility. Both is not
there.
Fixed.
It was fixed, sir.
You are not able to get any sound you get, something, the swelling is there. Are you able to reduce the swelling?
No, sir.
Okay. You said a hard, irregular swelling.
Sir, should she mention about movement with respiration here for a mass in the lower abdomen? Sir, Dr. Jailal.
Yes, ma'am. Even if sometimes if you have a large kidney mass which is there, you can have anything which has been directly or indirectly having a communication with the diaphragm can move.
Okay, if there is a space in between the causal margin and this, should they really talk about movement with respiration? Just to clarify for the students.
Divya, did you look for any rest of the abdomen for any percussion note or resonant note or a dull note, etc., etc.?
Sir, all over the abdomen it was resonant, sir, except over the.
Why you think it's a resonant note? Did you auscultate? Did you get any loud, noisy sounds, barbarigmy, etc.?
No, sir. Normal vowel sound was there, sir.
What do you mean by normal vowel sounds?
Sir, in 1 minute, like 2 to 3 vowel sound was heard, sir.
So why do you want to look for in this patient?
Sir, if ileocecal tuberculosis in that case, or in case of obstruction, early phase of obstruction, there will be increased peristaltic activity. So,
not only ileocecal tuberculosis, such a large mass according. So what I would have appreciated is if you were to say there's no, I didn't see any stepladder peristalsis or something like that, rather than flexion deformity and all that.
Exactly, absolutely.
What you mentioned, understand?
Yes.
So you have to look for those things because that decides your, you may have to take the patient for surgery. As a surgeon, as a clinician, patient like this comes with the peristalsis, you should tell your consultant, no? We need to take, is it obstruction? Right. Okay. Any other examinations you have done? Umbilicus, you mentioned normal.
Yes.
Any other examination? Look for umbilical nodules. You understand?
Yes.
If you are seeing.
Sir, your voice is.
Sir, is muted.
I am muted, sir. Rajgopal, sir.
You expect a exophytic growth or intraluminal growth?
Sir, intraluminal growth, sir.
So do you think the intraluminal growth will produce a very irregular surface and all the margins you will be able to define? Well-defined margin, you will be able to make it out?
If it will be, sir, big in size, then we can make also. Not in case of small swelling. But as size of the swelling is a big 18 to 6 centimeter size, you can appreciate.
Appreciate. Okay. Uniformly hard in consistency also.
Yes, sir, hard and consistency.
Proceed. Go to the next slides. Let us see. Why did you examine the genitals?
Yes, ma'am. I have examined. And to rule, ma'am, to rule out whether patient is having any undescended testis. So it
Tumor of undescended testis.
Yes, ma'am.
In the right eye left muscle. Okay. Anything else? Anything else in the testis can produce this mass?
Ma'am, one reason could be patient has gone for orchidectomy or anything, then patient may have the retroperitoneal germ cell tumor, like metastasis, it could be.
After orchidectomy?
If testicular tumor is there, then.
Yeah, you have to rule out even testicular tumors. So what is, in case it is testicular tumor, what do you think this right eye left fossa mass will be?
Then it could be, ma'am, because of the retroperitoneal lymph node, it could be.
Which one? You have to be very specific.
So testicular tumor will cause under right iliac fossa node.
The undescended
It
testis.
will be para-aortic region.
Undescended testis in the abdomen is not palpable. If it is palpable, means it's a tumor.
Yes.
It's a tumor. And which is the lymph node of the testis?
Sir, it is usually peri-aortocaval, sir.
Usually or what is
aortocaval,
aortocaval?
lymph node,
Aortocaval. Why you?
No, you must be very careful. Right side what you are saying, left side what you are saying.
Intercaval lymph node.
Oh, I don't get it.
Anatomy is very important now. You need to read. That's why we're all listing all kinds of questions to you.
It's
The lower
better,
margin.
it's better to say para-aortic and keep quiet. You understand? And you feel
Yes.
it is above the umbilicus, more in the epigastrium, large nodular mass there.
Not in
Yes,
the right
sir.
leg fossa here. No?
Yes.
Have you mentioned about the renal angle? You have not mentioned because you have seen all other findings.
I think
Yes.
she mentioned, I think.
Sir
No, she has
mentioned.
She
mentioned.
mentioned.
Okay, good. What is
If
that renal angle?
if you are suspecting a desmoid tumor, suppose, so where will be any other history or what is important in this case?
Ma'am, desmoid tumor, we should ask for the any other swelling in the body.
Madam has earlier also asked one question.
Sorry.
Madam has seen a scar also.
Previous history of any surgery.
Surgery. Okay. And site?
Yes, ma'am. Site of the swelling.
Yeah, where it is normally.
Desmoid tumor is usually, ma'am, like parietal swelling, ma'am, the midline.
Yeah. In this case, it is intra-abdominal. So it is less likely.
Yes.
Okay.
Still a diagnosis.
You are expecting left supraclavicular node you are searching for, no? With what hope, what expectation?
Intra-abdominal malignancy, it can metastasize to left supraclavicular lymph nodes, sir.
How it goes to Virchow node?
Through the cisterna chyli, it will go to the thoracic duct, sir, and from the thoracic duct, because of the obstruction, because of the tumor emboli, retrograde flow will occur and of the limbs.
Retrograde flow means it will come through the same thoracic duct. No, that is retrograde flow.
Sir, where the thoracic duct joins on the left side at the junction of the interjugular vein and the left subclavian vein, there the jugular lymph nodal trunk which comes from the head and left side of the upper limb joins. So through that route.
How does it go to the lymph node there? From this thoracic trunk that it enters at the junction. From there, how does it go to lymph node?
Ma'am, a lymph will generally travels through the cisterna chyli and then it will go to the join the thoracic duct.
You told all that. You told up to the junction it reaches also. From there, how does it go to lymph node? The next step.
Ma'am, because of the obstruction, because of the tumor emboli will obstruct that area, so retrograde flow through that channel will occur and.
No, obstruction, don't use that word, because where is that obstruction? What is that obstruction?
Sir, means that area will be involved because of the tumor, so retrograde lymph flow will occur and.
There is many other mechanism, not the obstruction mechanism. Okay. The pressure changes, the patient coughs when the intrathoracic pressure increases, they hit pushes that. So a lot of changes, but don't use the word just big obstruction. There is nothing is happening there. Okay. It's good you have find out that. Spine?
Yes, sir.
So what you are looking at?
There was no spinal deformity or any tenderness, sir.
No,
Sir, any spinal tenderness. For bony metastasis, sir.
What type of metastasis?
Sir, it will be osteoblastic.
Osteoblastic.
Osteoblastic? Which conditions cause osteoblastic?
Oh, sorry, ma'am. Osteosclerotic, ma'am. In CA prostate, it will be osteoblastic.
It's not called osteosclerotic, it's osteoclastic. Cystic, lytic lesions. Okay. Where do you see osteoblastic now that you brought it? This is how you invite problems, you know, AVL, right?
Yes.
You should be very careful when you stop. Be slow and steady, think and answer. Don't be in a hurry to just blurt out the answer. So just be calm. When question is asked, calm down, think and then answer. Okay? So
yes.
You tend to make more mistakes if you don't wait for the question to be completed and you want to just answer it. Right? Even
yes.
if you know the subject, there can be difference in giving the information. Just be calm and answer.
Have we looked for any edema in the leg?
Yes, sir. No edema was there, sir. In general physical examination, I have looked for it, sir.
No, very specifically, edema where?
You look for only edema there, and anything else also you look for, because he's a male patient.
Sir, in lower limb.
No, such a big mass. You said the 7 to 8 centimeter mass. It's a fixed mass in that region. Right?
Edema, I have looked for, sir.
Okay. Can you get varicocele?
Sorry, sir.
Can you get varicocele?
Yes, sir. It can be there, sir. Pelvic tumors.
So there is no signs of any obstruction there. No? That is because you said the abdomen is clean. So there is no signs of any obstruction there. Okay.
Yes.
Varicocele is common.
So how you are going to?
Okay, sir. Proceed, sir. Please proceed.
What you are going to do for this case?
Sir, my provisional diagnosis is, sir, carcinoma cecum, and the differential diagnosis are ileocecal tuberculosis of a hyperplastic variety, or it could be appendicular neoplasm. So first, I would like to confirm.
Why do you think of hyperplastic neoplasm? I mean tuberculosis this stage?
Sir, because mass is palpable, so in ulcerative.
You said patient is very cachectic. Patient is weight class. Is only BMI is only 19. Do you think the hyperplastic type of tuberculosis will be there?
No, sir, but in ulcerative, but sir, in case of ulcerative, not such big lump will be.
Hyperplastic lesion will not go for an ulcerative lesion, ma'am. So don't unnecessarily, because we have seen such a huge mass and patient general condition is poor. Don't try to think of hyperplastic lesion, and you are able to feel the mass at the right. And appendicular neoplasm is a clinical diagnosis.
Is it a clinical diagnosis?
Appendicular, sir, it could be appendicular mass. Appendicular mass, it could be. Sir.
Mass is different. You are making a diagnosis of neoplasm.
Sir, as patient
your
is
DD says it is
towards...
No one will make a clinical diagnosis of appendicular carcinoma.
Yes.
Divya, if at all, how to differentiate clinically if question is asked between tuberculosis and the carcinoma cecum? What quickly, clinically, based on your palpation findings, can you tell me few points? That's all.
Sir, history-wise, usually carcinoma cecum will be present old age history and
again you are coming to the.
You are very particular about old age. You are angry with somebody.
We are all old according to you. Okay.
No, sir.
No, I wanted to know only, madam, clinical straight away, because let us not waste.
Sir, in carcinoma cecum, mass will be in the right iliac fossa, irregular surface, well-defined margin, hard lump. It could be fixed or restricted mobility will be present. But in case of ileocecal tuberculosis, usually the right iliac fossa will be empty because of the pulled up cecum. So mass will be little higher up.
It is always, you should speak like this. If there is a pulled up mass, it is more likely of carcinoma rather than, it is not a rule. There's no rule like that, that the whole thing. If it is, if it is there in your case.
Then, sir, yes, sir.
And some amount of mobility will be there.
Yes, sir. And mass will be usually firm in consistency, sir.
Firm in consistency.
No.
Nodularity, they are all very vague finding. Firm nodularity. But one finding is a pulled up cecum and mobility.
And mobility will be there.
That is all. That is all. All the other points, please don't tell. You're in a hurry to tell all the points. Please don't do this in your exams. Don't do this in your exams.
See,
the only differentiating point between these two is the mass. In a carcinoma, it will be in the right iliac fossa. Yeah, and whereas in ileocecal, it is pulled up, and so mass will be more in the right lumbar region.
I will give you three possibilities of your so-called your appendicular neoplasm. I am not agreeing with that, but carcinoid, adenocarcinoma, mucocele of the appendix. Which one can be a big mass?
Sir, mucocele of the appendix.
So that is what you should try to understand. Don't expect adenocarcinoma, appendix, carcinoid and all attain such a large one in your. Better to cut that appendicular.
You shouldn't give the diagnosis only. Appendicular neoplasm should not be given as a clinical diagnosis.
Enough these two diagnoses. Don't get it.
Dr. Shenoy,
Sir.
When She sent me the PPT.
Sir.
I have put the diagnosis of the appendicular neoplasm. Okay, the reason for that is that this patient is definitely having the melena. Whenever there is a patient who is having a lump in the right iliac fossa, you make a diagnosis of carcinoma cecum, ileocecal hyperplastic tuberculosis, and appendicular pathology. Now, appendicitis, appendicular abscess, mucocele of the appendix cannot explain the melena in this. And that is why, keeping that melena in mind, I specifically kept a possibility of the appendicular neoplasm, which may be a appendicular carcinoma, which may be a appendicular carcinoid, which can present with a melena, because melena is a very important history in this patient. And that is why I have put specifically the diagnosis. In fact, I did not tell her that she must read about that, about the appendicular neoplasm, but I put the diagnosis of the appendicular neoplasm in the patient. I did not put any lymph node mass there because the patient had the melena. I did not put any other pathology here because the patient had a melena. Melena is a very important finding in this patient. So you have to give some differential diagnosis where there is a involvement of the lumen is there. And that is why I kept the that was my...
Why not it is a synchronous tumor in the GA tract, upper GA tract also?
No, that we found on investigation. We are only talking about this lump which is there. Lump and the melena.
Yes, sir.
You can put another thing of the gist here, okay? That you can see.
Yeah,
but because usually gist is extrahepatic variety, it will not cause the melena, usually. But it can ulcerate. Sometimes it can ulcerate inside and can cause the melena. So that may be another possibility in this patient which can be kept. Now, regarding, you were asking about the flexion deformity of that. If the student doesn't say about the flexion deformity with a lump which is there in the right iliac fossa, I will fail her or him there. He has to tell about the flexion deformity, because the cold abscess or the sauce abscess which is there is the reason for that. So you have to, the student has to tell about the flexion deformity. Then there was a question about the local temperature which is raised. It will occur in the parietal swelling. No, it will occur in a intra-abdominal swelling which has got a abscess there. So if the appendicular abscess is there, though it has not busted out on the parietal wall, you will find that the local temperature is raised. If there is a diverticular abscess is there, you will find that the temperature is raised in the left iliac fossa over the sigmoid colon, though it may not have perforated on the parietal wall. So that is a feature of the raised local temperature. So I think what she was telling about the raised local temperature, not only the parietal one, it has to be the intra-abdominal as well as the parietal.
But normally when they say, sir, even if there is an abscess, it will produce a generalized temperature, but not the localized temperature. That is the intra-abdominal.
No, it will be, sir.
Once it is there.
That is the difference between appendicular lump and appendicular abscess, sir. That is the difference between appendicular lump and appendicular abscess. Appendicular abscess will definitely have the raised local temperature there, while appendicular lump will not have that.
Whether we can exactly say it's a localized to the tumor is difficult, sir, because it will be always at least a quadrant. It is a temperature which is not due to because of the
temperature over the lump. Temperature over the lump.
Always produce a
that is the first sign. That is the first sign of palpation of any lump which is there. The student has to say that the local temperature is not raised and it is non-tender. These are the two first signs on the palpation. The student has to say
there is clinical some I think interpretation and sciences are differ from place to place, maybe how the teaching goes in like generally in our areas south, at least wherever I have gone, this kind of such a large mask is given as a differential diagnosis. We generally keep tuberculosis and carcinoma cecum. I'm not trying to say that third one is not possible or something. Yes, gist also is nowadays which is entertained as a possibility. If it is ruptured into the mucosal. We generally tell the student abdomen palpation first is soft and no guarding, no rigidity, and then a mass is palpable. That's how we start with. Anyway, So
tenderness also is accepted, sir.
And the flexion deformity, it will be just like that. What we say for a supraclavicular node separately, it will not come under the part of the examination of the abdomen. It will have to be said separately. It is better if they say separately on that. That will be much easier than, because you are examining the abdomen in a supine position most of the time. Then again, asking the patient at that position to go and walk to see the flexion deformity is little difficult for all the students. Unless if the SAR has already taught the student, then it is fine. But here we don't follow that.
But I think she has written separately, sir. It has not written in the abdominal examination. I think so.
No, no, it was the same page of the abdominal examination set.
Can you go back to your slide? So this is separate here, no? No spinal tenderness, no flexion deformity, renal length is not full, left supraclavicular lymph node not full. It's not in the abdominal examination. It is a separate slide for that, yeah.
First slide was showing, the previous slide,
Show the previous slide. Yes. Finish is there. Okay. On auscultation, she has finished the abdominal examination. And then she has gone to the next. Go to the next one. Yeah. After that, no. Next slide. Next. Inspection, palpation, percussion, auscultation. Yes. And next slide is now it is external genitalia. That is the, I think, sequence of that. That is the normal sequence of any abdominal examination.
Fine, sir. A candidate should have such a strong internal examiner.
That's why there's an advantage.
No, yeah. I think you know what I felt today, that she has just been ragged. Okay,
no,
what
sir,
I was feeling.
No.
Yeah, I was just feeling that. That was my impression, and that is why I come up with all those strong points.
We are correcting her.
No, but it is good. Okay, the candidate must understand that. Yeah, that's right. Yeah.
Divya, did you feel that way?
No, ma'am.
Yeah, we are correcting you because you'll be seeing all kinds of examiners.
Yes.
I never listened to
How will you proceed, ma'am? How will you proceed for this?
Sir, to confirm my diagnosis, I would like to go for the ultrasound of the abdomen. In that, sir, I would like to see the organ of origin, then its echogenicity of the mass, sir. Then I would like to see relationship of the mass with the surrounding structures, then status of the lymph node, then liver echo texture, sir, and then any ascites, whether it is present or not, sir. Then, sir, to confirm the diagnosis, I would like to go for, sir, a colonoscopy.
Suppose there is a, do you think an intestinal mass, intestinal lesion arising from the hollow viscous ultrasound will be able to give a clear picture of that mass is arising from that?
No, sir, but it can give at least idea about the organ of the origin, sir, and it is the investigation which is usually easily available in the hospital. So, as a extension of clinical examination, first I would like to go for the
investigation. Given a priority of a intraluminal lesion, will you do for a colonoscopy or ultrasound?
Sir, if it is confirmed that it is intraluminal, then first I would like to go for the colonoscopy, sir.
So as a clinical extension of your clinical, you will do the ultrasound. Ultrasound is not the confirmatory or not be able to say, especially in the luminal mass. So your confirmation will be by the colonoscopy.
Colonoscopy and biopsy. Then, sir, in the colonoscopy and biopsy, I would like to see about the extent of the mass from the index mass from where to where it is, and if mass is there, then I would like to take the biopsy from the mass. Then I would like to see for any synchronous lesion in the other area of the bowel in colon, sir, and then if any associated polyp is present or not, sir.
Good, that is good.
Why do you want to look for the polyp?
Sir, in colon, there are various types of polyp which are pre-malignant. So if it could be there, then I would like to.
So which polyp will more prone for malignancy?
Usually, sir, adenomatous polyp and the serrated polyps.
Which polyp?
Serrated polyps and sir, adenomatous polyp. In the histopathology, if it is the villus varieties sir, and the tubular villus varieties, then.
So suppose why you want to look for the polyp?
Sir, there are various hereditary syndromes where the patient is having multiple colonic polyps or the GI polyps, which will prone for the patient for the recurrence of the colorectal cancer, sir.
So if there is, you are making out a polyp somewhere, or you are diagnosed, your treatment is going to change or not?
So if the polyp is in the area which I am going to resect, then it will not change the management. But in case if the polyp, as in this case, sir, the patient is having right colonic mass. So if the polyp will be present on the left side, then it can change the management, sir.
No, you mean to say if the polyp-induced malignancy also, you will do only a localized resection?
No, sir. Like in case of if it is confirmed that carcinoma cecum and patient is having resectability status, then I would like to go for this case as right hemicolectomy. But if patient is having multiple polyps which are having high risk features in the left side of the colon, then I would like to go for the colectomy, sir. So in that way, it can change the management plan.
Basically, you want to rule out what?
Sorry, ma'am.
Basically, you want to rule out what?
Ma'am, whether patient is having any hereditary cause of the
polyposis, you want
I think somebody is speaking. Swagata, Dr. Swagata, please mute yourself.
Then, sir, after the colonoscopy and biopsy, to stage the disease, I would like to go for the contrast enhanced CT of the abdomen and pelvis. There, I want to see about the extent of the tumor, from where to where it is, then its relationship to the surrounding structures, relation of the tumor with the vascular structures, then lymph nodal status, then whether any peritoneal or liver metastasis is there or not, then ascites is present or not, and about the resectability of the tumors.
Local infiltration, what is more important for you to see?
Ma'am, lymph nodal mass and metastasis to the liver, ma'am.
Anything else is there in that region which is important and we should be careful about?
Ma'am, locally, like, are you asking?
Yeah, locally, yes. You said surrounding structures. So what is more important? Which is
Canada, there is a lot of disturbance.
Someone's TV is on.
I'll work on it, sir.
Any retroperitoneal structures, whether it is involved or not locally.
So you have seen the colonoscopy, you are seeing, confirm your diagnosis. Now, next, what is the next stage you will go?
So CECT abdomen, sir, with pelvis.
For
to
what?
stage the disease.
Okay. Stage the disease means what? How we are going to stage that?
Sir, to see, because clinically, sir, I cannot comment upon the whether lymph node is present or not, and we cannot sure about the metastasis status. So with the CECT abdomen and pelvis, I can comment upon the nodal status and the metastatic status, sir.
Okay. So only what is the nodal stage in that staging?
Sir, in the TNM staging, N1 is divided into N1A, where one regional lymph node is positive. N1B, sir, 2 to 3 lymph nodes are positive. N1C, sir, no regional lymph nodes are positive, but tumor deposits are seen in the serosa or the lymphatic channels in the mesentery.
Can you tell me other carcinoma you know where this the same type of nodal staging is there?
Sir, rectal.
No, this colon is same. Other than that, other than GI, I mean lower colon. It is there in the ovarian cancer also. You will have the same N1, A, B, C. And melanoma staging also, you will get similar features. It's a N1AC, when that is a intermittent. So these only 3 cancers, you are getting that N1A, B, C feature there.
Yes.
Okay. N2 and N3.
Sir,
N2A and N2B.
N2A is if there is 4 to 6 regional lymph nodes positive, and N2B is more than 6 regional lymph nodes are positive.
So you have done a CT for this patient?
No, sir. I don't have any investigation report.
So what else you will look into that? Any other investigation you do for the metastatic staging?
So CT of the chest should be done, sir, to see the lung metastasis.
Is it a CT abdomen you are doing only for your nodal status to see?
CT abdomen, sir, about the resectability also, sir, then lymph nodal status, then any malignancy, metastatic malignancies in the liver or any surrounding structures, or the peritoneal metastasis, whether ascites is there or not, sir.
So if there is a metastasis in the liver, is it non-resectable?
No, sir, it can be resectable, sir.
So what do you look for that? Any other finding? There is a metastasis in the liver is also there. You are seeing a nodule in the liver.
Yes, sir.
Any other tumor marker you will study?
Yes, carcinoembryonic antigen, sir, I would like to go for.
So that is also significant only. Then you have to be a little more cautious in taking the decision whether you are going to do resection of your secondary. So now if you say that there is a nodule in the liver also, which is inoperable, and your stomach, the colon is also involved, and what do you want to do? Or you want to go for neoadjuvant therapy or going to go for surgery?
Sir, if the patient physical status permits, then we can go for the upfront surgery.
You have your patient, Divya. You have your patient. So just tell me what you want to do.
In your patient, will you give a neoadjuvant therapy in ascending colon growth?
No, sir. Usually there is no role, sir, of neoadjuvant chemotherapy.
So either you go for an upfront surgery, and if it is not operable, you can go for an upfront chemotherapy. You can go for. So there is no called the neoadjuvant therapy.
Yes.
So what surgery you are planning for this case?
Sir, right hemicolectomy, sir.
So what do you remove?
How will you classify this? Right colectomy you do for the brain lesion also. Is there anything specificity when you are talking about right colectomy here?
Sir, radical right hemicolectomy.
Yeah, be more specific like that. Radical has to be mentioned. Means what, ma? Radical means what?
Ma'am, in this, like, we will ligate the vessel near its origin.
Origin. Okay.
So what is your extent of resection?
Sir, proximal 1/3 of the transverse colon, sir, till where the right branch of the middle colic artery supplies.
And from where?
Sir, ma'am, proximal to ileocecal valve, around 10 to 15 centimeter of the terminal ileum will be removed, ma'am.
No, please remember there is no centimeter is mandatory. When you do the root first, you are going to the mesenteric root first. Then after ligating the mesenteric root, you are going to look at the lumen and how much the bowel is gone for a gangrene.
Yes,
how much the bowel is gone to non-viable. So don't go with a fixed idea. I will go only the 10 centimeter. I will go with the 15 centimeter. Sometimes if the vessel is extending beyond that also. So you will take after ligating the root. That is why we always go by the root first approach. So you go the update. You see that how much is viable, and you are taking the distance. Minimum, what should be the target? 5 centimeter above and below the minimum target we'll give, and are going to do that. So what are the vessels you will ligate?
Sir, ileocolic pedicle, then right colic pedicle, and right branch of the middle colic artery, sir.
So you go from medial to lateral or lateral to medial?
Sir, usually in explorative laparotomy, we can go for the lateral to medial approach. Sir, in laparoscopy, usually medial to lateral is a better option.
So which one you do? Yeah.
Sir, I will go for the lateral to medial approach, sir.
Open. Okay, where do you make the incision cut first?
Lateral to medial, ma'am. First, I would like to go to the retroperitoneal plane. So I would like to, in the line of TOLD, I want to reflect the cecum and the ascending column up to the hepatic flexure.
So what are the structures you should be careful about when you do this?
The right ureter and the gonadal vessels and the duodenum, ma'am.
This is what I asked you from the beginning. When you say local infiltration, you have to look at the ureter. Okay?
Yes.
That's what you're supposed to look for. So, tell us anything else.
You have done that, and suppose your case is in an inoperable stage. That is not possible to do. How will you manage that case?
So we can go for the chemotherapy, the Folfox regimen chemotherapy. I would like to go.
We'll leave the patient. Won't patient develop any obstructive symptoms?
Right hemicolectomy with diversion stoma for obstruction case. I would like to go for, and then new chemotherapy. I will Folfox chemotherapy. I would like to give.
Okay, if the patient had come in obstruction, what you would have done? And patient, you just wanted to try it over the crisis. What do you want to do?
Ma'am, if patient will come with the obstruction feature, then I will go for the right hemicolectomy with stoma, ma'am.
What stoma?
Ileostomy, ma'am.
Why not transcolostomy? I mean,
ileostomy is better to manage, ma'am.
No, first of all, my question was wrong. It's ileostomy only. The growth is in the cecum, right?
Yes. Okay.
Why you want to make a stoma in a patient of a right hemicolectomy? Where there's a fixed growth is there. Why you want to make a stoma?
A stoma.
Sir, if patient is coming patient is coming with the obstruction, then there would be bowel will be dilated, and also there will be more risk for the leaks, sir. So
you will not do iliotransverse bypass?
Sir, iliotransverse bypass I will do, and the covering stoma, sir.
Why? Why do you want to have a stoma?
Iliotransverse bypass.
Why you are after the stoma? You know, stoma is so difficult to manage. Okay. If there is any obstructing growth is there,
yes,
and you are not able to resect, resection is the best possibility. If you are able to resect it, you should resect. But if you are not able to do, then simply do iliotransverse bypass. That will serve the purpose. The patient will be relieved from the obstruction.
Yes.
Okay. So
yes.
Stoma will be in a exceptional cases, you know.
Yes.
You think that anastomosis, because in these patients the bowel is almost, though it is dilated, but it is a healthy bowel.
Yes, sir.
Iliotransverse is so whenever in emergency you get a patient like that, do only the iliotransverse bypass. Do not do stoma.
Yes.
Okay?
Yes.
Divya?
Yes.
See, after doing radical right hemicolectomy, what is your choice of anastomosis, whether it is end to end or end to side?
Sir, end to side, because in end to end case, sir, there will be luminal disparity. So better to go for end to side anastomosis, sir.
Which side end and which side side?
Sorry, sir?
Which end and which side?
Sir, ileum side will be end, sir, and transverse colon side be side anastomosis.
And if you want to be more sure, do the side to side.
Side to side. Yes.
Side to side. If there
side to side. Better vascularity.
Why does a colonic anastomosis is likely to leak? What are the various reasons for that?
Sir, usually there are various factors, like the anatomical factors, sir, in the colon, presence of appendices epiploicae, then presence of hostrations, then sir, there is no circumferential longitudinal muscle in the colon. It is in the form of tinea coli, which is converged at 3 points. And water-said zones are there, sir, in the colon. These are the anatomical factors. Then, sir, in case of physiological factor, stools are more in the contact. Time duration, sir, is more for the exposure. Then strong peristaltic waves are there in the colon. Then high bacterial loads are there in the colon compared to the small bowel. While sir, in colon, high urinase enzymes are more in concentration, so there are more chances of leaks. Sir.
Do you know which is the longest part of the colon?
So transverse colon, sir.
And after the transverse colon?
Ascending colon, sir.
Sigmoid colon, you know?
Yes.
Sigmoid colon, then ascending and the descending colon.
Yes.
Shall we wind up, sir? Dr. Kanagavel,
Yeah.
sir? Good, Divya, good confidence you expressed.
Thank you.
But as I said earlier, it's better if you go a little slowly than, allowing the examiner to catch up what you are saying. Good.
Yes,
good.
Thank you.
Keep it up.
Thank you.
Thank you, Dr. Khanna, sir. I think she's your student.
Yes, she's my
Nice.
student.
Both of them, I think.
Yeah, both were my students. Both are very good. Both are very good. They have been placed in TISA number 1, number 2. In other also, like scope is there. They are number 1, number 2 there. So they are very good students. Both of them are very good students.
Good. All the best to you. All the best to the other doctor also.
Thank you,
his name? Your co-PG.
Dr. Aviral, yeah.
Aviral. Good luck to you too, Dr. Aviral. Sir, shall we?
Well done. Both the students have done very well, I think. Any question you have?
Divya, do you have any questions?
No, ma'am. Thank you.
Good.
Fine. Thank you.
Thank you, sir. Thank you, Dr. Ajay, sir.
Thank you, madam. Yeah.
Bye-bye.
Kanagavel, sir, thank you.